think it's 10:20, so we're going to get started just so we can make sure to give the presenters as much time as possible. So welcome everyone to the Health Factors and Behaviors Poster Center session of the Health Disparities Research Symposium. Very happy to have you all here. I'm Dr. Leah Carliner. Dr. Alka Kanaya, who's listed on the program, wasn't able to be here today to moderate, so I'll be moderating. We have 5 excellent poster presenters, presentations. They're each going to have 5 minutes to present, and then we'll have a few minutes for Q&A. But we want to make sure we get everyone a chance to present, and then at the end, if there's any extra time, we can have more questions. Alejandro Rincon is here from the office of the ODO and is very kindly going to monitor the chat. So if you want to put your questions in the chat, I don't think we have a Q&A button here, but we have a chat button. You can do that, and she'll be able to then direct some of those questions for the presenter right after their presentation. I'm going to share my screen with their posters. I don't think that you'll be able to see the presenter at the same time you can see the poster, unfortunately, but just in case, presenter, show your face, and then we'll see how we can manage that for the Q&A. And I haven't had a chance to ask everyone how to pronounce their name, so I apologize, and please repeat your name with the proper pronunciation, particularly if I get it wrong the first time around. So I think we'll go ahead and get started. So I'm gonna share my screen and then start this session. Let's see. Oh, it looks like we can see everyone here. So we'll be starting with Brandon, and this is a pronunciation problem I'm going to have. Is that Kai or Sai? I'm not sure. Apologies.
Yeah, that's right. Last name is Tsai.
Sai. Okay, thank you. And if you want to go ahead and pin Brandon so you can see them clearly while they're presenting, you should be able to pin them. And I'm going to start the timer, Brandon. And can everyone see the time down here on the bottom?
Yeah.
Yes, we can. Thank you.
You'll be able to see that you have 5 minutes. Okay. So you'll want to unmute, Brandon, and I will mute. Go ahead.
All right, sounds good. Thank you. So good morning, everyone, and thank you for this opportunity to share my team's research study findings with you all. So as we all know, hypertension is an important chronic illness affecting about half of US adults, with significant impacts on patients' quality of life, has many comorbidities, and is a risk factor for many other diseases. It is difficult to achieve good control despite medical treatments. Recent studies found that self-measured blood pressure monitoring can improve hypertension management, and our randomized controlled trial study examines blood pressure outcomes among participants receiving health coaching with SMBP versus self-led use of an app. So our ongoing study enrolled 88 participants so far in 2 cohorts during pre-pandemic and during the pandemic period, respectively, with a recruitment goal of 150. So we recruited adults with uncontrolled hypertension and randomized them into Arm 1, providing health coaching from student coaches and blood pressure cuffs for SMBP, and Arm 2, providing only general health information and the usage of an app from a pre-selected list. We monitor blood pressure changes via 6 and 9 months measurements and surveys, and this is demonstrated by the study timeline on the bottom left of our poster. Instead of looking at our primary outcome for blood pressure improvements today, here we performed a stratified analysis at baseline by educational attainment to examine differences in health factors and behaviors. Ranking education levels in order, we define Group A as those who completed K-12 education, 2-year associate degree, or vocational school, and Group B as those who completed 4-year college, graduate school, or professional degrees. Looking at Table 1 in the middle, we can see the stratified sample size was approximately equal, with 38 participants in Group A and 15 Group B. we examined survey items that were indicative of health factors and health behaviors, which were social isolation, unemployment, smoking history, frequency of primary care visits, and physical activity. The results revealed apparent differences. Compared to Group B, Group A, which is the group with fewer educational attainment, has 2.46 times the odds of being impacted by social isolation, 4.06 times the odds of being impacted by unemployment, and 1.88 times the odds of reporting a smoking history. Although the two groups did not exhibit a significant difference in the amount of time spent on daily exercise. Looking at the two visualizations on the bottom, we can see that Group A, which is the red bar, exhibits higher proportions of social isolation as well as smoking history as compared to Group B, which is the green bar. Although two proportions z-test reveal p-values to be larger than 0.05, we speculate that's potentially due to our current smaller sample size. Our stratified analysis reviewed elevated proportions of commonly studied high-risk health factors and health behaviors, as well as social determinants of health, including social isolation, smoking history, unemployment, etc. To help mitigate such health disparities, interventions must incorporate awareness of possible correlations between educational attainment and lifestyle factors when assessing hypertension risk. Similarly, improving equity in educational attainment itself may ameliorate certain risk factors that impact blood pressure. Further research is also needed to assess other disparity categories, and our next step for this study includes data collection at 6 and 9 months, especially for our cohort 2 during the pandemic, followed by analyzing effects of SMBP and health coaching versus self-use apps on systolic as well as diastolic blood pressure measurements. So with that, thank you all so much for your time and attention. I'd like to thank our study funder, Dr. Jeffrey Thomas Strokes Shield Foundation, and I'd like to especially thank our team and co-authors for the collective effort on this research project and the preparation of this poster and presentation.
Great, thank you so much. I want to open it up for questions for Brandon. I don't know if there's anything in the chat yet, Alejandra.
Nothing yet. I'm just trying to encourage people to put their questions there. They might be thinking about them, and so they might come a little later. Thank you, Brandon.
I have a quick question for you, Brandon. So you had relatively small numbers still, and I'm wondering if you're able to, whether there's any interest in looking at the cohorts differently, or whether you've seen differences in who you're recruiting at the baseline and during the pandemic in terms of types of patients who are participating.
Sorry, I couldn't really hear towards the end.
Oh, I don't know. There's some background noise. I don't think that's coming from me.
Yeah, we need everyone to mute themselves, please. Thank you.
Yeah. So my question is about any differences in the cohorts in terms of who you were able to recruit, who the study was recruiting pre-pandemic, and who's being recruited remotely during the pandemic, and whether or not those might be different kinds of people, and who might have different kinds of health behaviors going on, or whether they're looking fairly similar.
Yeah, thank you. That's a great question. It's something that we've been thinking about ever since the pandemic started. So what we're trying to do is, since we already have 2 separate cohorts, we're going to try to code a dummy variable into representing COVID-19 time period status. So say cohort 1 we speculate it to be different from cohort 2 in terms of demographics as well as behavior and risk factors. Also because our enrollment direction shifted due to the restrictions of our study. But we will definitely be looking into it in our next phase of analysis.
Great. So if there aren't any more questions for Brandon right now, feel free to put them in the chat. We'll return to questions at the end of all the presentations. So I'll just, Alejandro, stop me if I shouldn't move on.
No, yes, please go ahead, Leah. He's getting a lot of kudos on the chat, so good job, Brandon.
Okay, nice. Make sure to look at the chat. So, okay, so I'm going to move to our next poster. So hopefully it'll come up. This is Andres Calvillo. going to be talking to us about patient-specific factors influencing adherence to follow-up imaging recommendations. So I'm going to go ahead. If you're ready, I'll go ahead and start the timer. You
Yeah,
good?
can you hear me okay?
Yes, I can hear you. Great. Okay.
All right, so hello everyone. My name is Andres Calvillo, he, him pronouns, and I'm a fourth-year medical student at UCSF. As mentioned, my poster is titled Patient-Specific Factors Influencing Adherence to Follow-Up Imaging Recommendations. And I want to give a quick thank you to all the authors listed and Scarlett Lynn Gomez for their contributions, as well as all of you here today for your attendance. So for background, there are multiple studies that have determined adherence rates of imaging recommendations ranging between 32 and 69%, and being associated with modifiable and non-modifiable factors. The radiology department's role in identifying incidental findings, addressing early intervention, and guiding management is underutilized when patients are lost to care. So when patients are lost to care, there can be a delayed use of advanced imaging, which has been associated with longer hospital stays, increased mortality, and higher costs to hospital systems. So after a patient completes an imaging study, a report is produced by the radiologist, and depending on the findings, there may be a recommendation in the prep session to complete an additional follow-up imaging study. And there have been systems developed to more effectively communicate imaging findings to the patient. The adherence remains low and therefore poorly understood. The purpose of our study was to determine which patient-specific factors were associated with differences in adherence to follow-up of these imaging recommendations. To answer this question, we designed a retrospective cohort study collecting radiology reports over the course of the 2017 calendar year. Via a database search, we extracted charts from our EHR that contain the word recommend or any modification or synonym of the word, specifically in the impression section of the radiology report. We then analyzed 1 month's worth of recommendations as a representative sample of the whole year and excluded any reports that recommended anything other than follow-up imaging. And we also excluded reports where the patient did not follow up clinically at all within the expected time given in the recommendation. Of the 1,118 individual reports we analyzed, 308 had corresponding follow-up imaging present in their chart. We documented demographic factors, including gender, race, ethnicity, language, and then using a multivariate logistic regression model to evaluate each of these variables, we found that patients with commercial insurance had over 4 times greater odds of completing follow-up imaging recommendations when compared to patients with Medicaid. And so kind of to put this in perspective, our study demonstrates a need for radiology departments to be more actively engaged in understanding the effects of barriers to care across different groups and being actively engaged in developing workflows that help to mitigate these barriers to further improve these adherence rates in the future. So with that, thank you to everyone for your attention and happily take questions.
Thank you,
No
Andres.
questions yet on the chat. Thank you.
Give everyone a minute while I ask I'm going to always have a question, so, but I had an advantage of reading this last night. So I had a little bit of a question about the follow-up piece in terms of excluding people. So, you know, it may differ whether often things are followed up over the phone or, you know, or even by my chart, if this is within UCSF, I think, right? So were you including that kind of follow-up, or were you only including in-person or telehealth visits?
So we were only including either based off of notes in the chart, just so if they had another follow-up visit clinically as like a clinical note, then we would assume that they were following up just in general to the clinic. And then for follow-up, we specifically looked at the imaging report. So whether that was present or absent based off of the recommendation. And since we only were looking at UCSF we weren't looking to see if they finished the follow-up imaging recommendations at an outside system. That we couldn't reliably and consistently check that for everyone, so we had to exclude those people for this study.
Thank you. Any other, I have a follow-up question to that, but I'll wait and see if anyone else has any other questions.
Nothing yet, Leah.
Yeah, so just one quick follow-up question to that. So I'm a primary care internist, so I order a lot of radiology, which is, why I'm wondering, there may also be, it may be interesting to further look at sort of whether someone had, say, a MyChart interaction on the patient portal and then got follow-up or didn't get follow-up. The people with MyChart may actually be more likely to get follow-up quickly because that's an easy conversation. No one's picking up the telephone, or whether they had a telephone, you can look at telephone encounters as well. Because we do a lot of our follow-up in that way. I wouldn't necessarily wait for someone. I have a 2-3 month wait to get in to see me. So I wouldn't necessarily wait for someone to come see me to follow up on a radiology study. If you may just have different, and then there may be differences by who has MyChart versus telephone that might be interesting to explore. I absolutely agree with your conclusions, but there you may find some additional areas of leverage of people that may need more attention if you look that way.
Yeah, thank you. That's a great insight, especially from the primary care side.
Great. Shall we move on, Alejandra? Other?
Yeah, let's keep moving, and I'm hoping that either for Andres or for Brandon, there'll be some follow-up questions maybe, but let's just keep moving. Thank you, Leah.
All right, thank you.
Thank you for sharing your work, Andres.
Oh, I think I might have gone too far. They changed the order on us. Let me just make sure. I feel like it's skipped, but maybe not. So, Elissa, it looks like yours is coming up next. So I hope you're ready to go. I know I told you you'd be last, but are you there?
Yes, I'm very
Okay.
happy to present.
Great. So Elissa Hamlat's going to present to us on effects of early life adversity on pubertal timing and tempo in Black girls.
Okay, so there's a known relationship between adversity in early life and poor health outcomes across the lifespan, most notably in cardiovascular disease. But these kind of mechanisms that might be connecting the two are pretty unclear. So I tested one potential association between early life adversity and earlier pubertal maturation. So earlier pubertal development, so maturing earlier than others of the same age is, there's a known relationship between early pubertal timing and poor health outcomes as well, most notably cardiovascular disease, among others, particularly for girls. But it's not really known if this relationship is specific to events of abuse, which have been most likely tested, or if it generalizes to any kind of early adversity events, that those might be related to pubertal development. It's also been looked at primarily in white samples, so it's not known if there are race differences in this relationship. And lastly, there's some indications that early adversity might affect not only the timing of how early you develop, but also the rate at which you proceed through puberty or pubertal tempo, but that has also not been looked at. So I looked at early life abuse and non-abuse adversity in a large sample of Black and white girls to see if there were race differences and if adversity affected the timing at which they began puberty, as well as the rate at which they proceeded through puberty. I was lucky to have on hand data from the NGHS study, which examined girls starting at ages 9 and 10 in the late 80s. First, we had annual assessments of pubertal development over 10 years. And these women are now still being followed up as they enter middle age. And so recently we asked them to come and complete an interview of early life adversity. It is retrospective since that was not examined in the first part of the study. Because we had physical examinations, I was able to look at pubertal development in terms of areolar and pubic hair development at age 10, as well as how that proceeded across to age 16 each year, as well as menarche, which is the first age of menstruation. To look at relationships between adversity and menarche, I just did regressions, but because I had all these nice time points for areolar and pubic hair development, I did growth curve models where timing was the intercept or development at age 10, and the slope was tempo or rate through puberty. And I found that indeed, as expected, early pubertal timing was associated with early adversity, but it was specific to abuse. Having more abuse predicted an earlier or basically more development at age 10. But it also predicted abuse, again, only predicted a slower tempo. So the more abuse you had, you proceeded at a slower rate through puberty, which was somewhat surprising, although there has been some early evidence to suggest this. There were no race differences, so this relationship between adversity and pubertal development held for Black and white girls. However, there was an effect difference in that for Black girls with the same amount of abuse, they had more development at age 10 and were slower across the years than white girls with the same level of abuse. So although it did seem that abuse predicts early timing and slower tempo for all girls, it seems to have a larger effect for Black girls. I've looked into the lit, and there's a hypothesis that basically having a risky environment might signal that you need to reproduce early rather than late, get before you are put out of the gene pool, and that it could be that the factor explaining the race difference is one of an environment of institutional racism might signal that this is an especially risky environment, and that provides an added boost to the effects we saw with Black girls. But basically my message is one of screening. If we know girls with early adversity and early pubertal timing have poorer health, this is a way that we might be able to identify them early and certainly intervene. So thank you.
Thank you, Elissa. Have a moment for any comments or questions in the chat.
We have a very quiet chat today, Leah.
I know.
This was a wonderful presentation.
Thank
As all
you.
the other ones.
Thank you.
Elissa, I do have a question. So, and I'll do my best in framing the question, not being a physician, but if I understand you correctly, you said this children, or I guess young people, teens, preteens, proceeded slower through puberty, even though they have gone through abuse, which is a bit counterintuitive, I imagine. But how does that compare maybe with socially, how they, because there's their I guess, medical development or their child development or into teens, and then there's their social development. Was there any information about that?
No, but that would be a great thing to look into. And actually, there was recently an interesting study in Puerto Rico that found the same kind of relationship. Adversity predicted a slower tempo. And so the earlier timing, that's mostly risky, we think, in a social dimension. I'm actually a psychologist, so that, girls that mature early are treated very differently, treated as sexual objects. They're also treated differently. They might start having friends, that are older and have riskier behaviors. But the slower tempo, you wouldn't think that would have such a social cost. And so that might be something more like exposure to estrogen or something that might be related. Because the thing is, I was very broad, but it seems like early adversity and early timing are associated with certain forms of cancers, including breast cancer. I'm also not a physician, so I don't know in depth why this relationship would be, why slower tempo would be predicted by adversity, and why that might in turn be associated with poorer health. It's possible it's just a relationship of a catch-up thing. Like if you're maturing early, you're, by nature, there's going to be an association that if you're offsetting around the same time, maybe you're just slower. So this might be just kind of a like spurious relationship. But there are people looking into this because it does seem like, because you think a faster tempo would be more, I don't know, upsetting to children, or and there has been some indication that in boys, early timing isn't so bad, maturing early, but faster seems to be worse. So I think it's just really important that we always look at race and gender and other individual factors when we look at puberty and its effects on children. But yeah, this tempo thing is really early days. It was just basically, I wanted to look at another measure. Yeah, and so people have asked some really good questions, and people have almost always looked at the fact, so Black girls on general mature, even if, taking away any kind of effects of adversity, mature about a year earlier than white girls. And a lot of times people have always pointed to, oh, this is like a biological difference. But a lot of times they haven't looked at any individual factors, because although there is, a huge biological genetic factor in pubertal timing, you're most likely to mature similarly to the time frame of when your mother did. Social factors actually play a huge role, and we know this if you look at history. So I actually, I do think, as in response to Joy, that social factors actually play a huge role, and that they just kind of have assumed to be biological differences, or they just haven't. I mean, most of the research on puberty, I looked at it in the it was always white middle class girls, which really surprised me. And I did stratify results by type of abuse, in that I was able to categorize things as abuse, which was physical, emotional, and sexual. And then unfortunately, I didn't have enough to really categorize types of events. I was getting too piecemeal. So everything else was just considered to be non-abuse. So those were still very major events, like death of caregivers and things like that. And yeah, thank you, Connell and Marycon. And yeah, I think ideally this thing I am looking at, trying to look at race as a social construct, especially in puberty research, which people tend to go to the biological explanation, first and foremost. And I think that kind of limits us in actually doing maybe some intervention in this area too. I also don't think early puberty has to be a negative factor. I think it also, I look also at the intersection of puberty and stress. So also how that might play out across the lifespan depends upon the context in which the maturation takes place and later life. So thank you very much.
Thank you, wonderful. And thanks for your questions in the chat. Getting the chat going a little bit better. All right, we're gonna see whose poster comes up next. Yes, okay. So we're going back to poster 16. Marycon, I think that I may be mispronouncing your name completely. I apologize. Will be speaking to us about disparities in eye health knowledge, attitudes and practices among older adult Filipino-Americans from San Francisco Bay Area. Are you able to show your face on video?
Yes.
Okay, there you are.
Can you hear me?
Yes, I can.
Okay, perfect. Thank you for that introduction.
Please tell us how to pronounce your name correctly.
Yes, of course. Hi, everyone. My name is Marycon Jiro. I go by she, hers, and I am a third-year medical student and master's student at the UC Berkeley UCSF Joint Medical Program. I am also a part of UCSF's program in medical education for the urban underserved. And today, again, I'm really excited to share my research on ang ating mata, disparities in eye care knowledge, attitudes, and health-seeking practices of the older adult Filipino-American population in the San Francisco Bay Area. So as a quick introduction, Filipino-Americans are the third largest Asian American group in the United States and the largest Asian American subgroup in California, with an average age of 48 years old among foreign-born Filipinos. So in the San Francisco Bay Area alone, it has the second largest Filipino-American population. And so there's already a lack of literature on Filipino-Americans, but the studies that do show it focus on cardiovascular disease. There's a limited literature assessing the state of ophthalmic care engagement. And so this is concerning because there is a high prevalence of type 2 diabetes mellitus and hypertension within this population, as well as other structural inequities. And all of these can lead to worsened eye health. We know that timely eye examinations, appropriate treatment, and health education are necessary to reduce visual impairment in this key and aging community. And so for our research, we are conducting a cross-sectional quantitative study, or we did conduct a cross-sectional quantitative study using a modified knowledge, attitudes, and health-seeking practices survey to 40-year-old Filipino-Americans living in the 9 San Francisco Bay Area counties. UCSF IRB approval was obtained. The survey was live between June to August 2020 and was offered in both Tagalog and English, either online or phone. And this was to capture hopefully a wide range of different socioeconomic classes. And a $5 gift card was given to each participant. For analysis, associations between eye health knowledge, attitudes, practices, having a primary care provider and insurance, age group, immigration status, education, acculturation, and socioeconomic status were analyzed using chi-squared analysis and students' t-test through Stata software. And so for our main findings, we reached an N of 256, 76% identified as male. The top 3 counties that were represented was San Francisco, Alameda, and San Mateo. Majority of respondents were between 40 to 54 years old, followed by 54 to 64 years old and 65 years old and older. And the majority of the respondents' household income was between 50 to 90K. So focusing on the knowledge aspect, we found that only 40 to 50% of the older adult Filipino-American study population were aware of different eye diseases such as glaucoma, diabetic retinopathy, cataracts, and macular degeneration. Those who were least knowledgeable were those born in the US, and those who were younger on the older adult scale at 40 to 54 years old. For attitudes, we found that 95% stated that vision was extremely, very, or moderately important to them. 97% stated that having an eye doctor is extremely, very, or moderately important. And 90% worried about their vision almost or some of the time. For practices in our specific study population, a high proportion were receiving eye exams within the past year at 81%. 92.5% have had a dilated exam throughout their life. And we found that those who were least likely to have had an eye exam or their eyes dilated were those who were low income, who were younger on the older adult scale at 40 to 54 years old, who had no eye insurance, no health insurance, no primary care provider, had a lower acculturation score, and were a recent immigrant within the past 20 years. And so in conclusion, the gap in knowledge that we found is concerning because it suggests that there could be a lack of outreach in the community in general about eye care, and it's a public health concern. Better and more culturally sensitive patient education materials and media should be provided and made accessible for this large minority group. And while the study shows that a large proportion of Filipino-Americans in the Bay Area from our study population are receiving the appropriate eye care, there is a delay in receiving care amongst different groups. This may also be because of the fact that this was sent out during the height of the pandemic, and we were only really able to do online surveys, which limited the amount of outreach that we could do in person. And lastly, vision screenings and educational outreach interventions in low-income new immigrant communities should be provided to address the needs of the most vulnerable demographic. And some of our next steps are to conduct a qualitative study to further tease out the nuances of the needs of this population. So thank you.
Thank you. Great presentation.
We don't have any questions yet on the chat, but we obviously encourage everyone to send us questions, and thank you for your encouraging comments to Marycon. Good presentation.
I do have a quick question. I'm wondering whether there might be a correlation between the age groups and immigration status. For example, are the old people in the older groups more likely to have immigrated earlier? And might that be
Yes,
or later?
Yes, definitely. I think that is one of the correlation factors for that as well. I think some of the next steps that our team has to do is just try to tease out the co-founding factors to make sure that we're able to present the data in the proper way. But yes, that is a good thing to note. Thank you.
Great. Thank you. I'm gonna move us along because we're late. We're short on time. I want to make sure we have time. We have one more presenter. Hopefully that will come up now. Yes. So our final presenter is Luis Rodriguez. Appearing. There we go. Talking to us about capturing modifiable obesogenic behaviors in primary pediatric care among Latino adolescents. Luis, are you there?
Excellent. Thank you, Dr. Carliner. Can you hear me okay?
Yes.
You pronounced my name very well. Thank you for that. I am an epidemiologist by training, currently a research fellow at Kaiser Permanente Division of Research. This work is a pilot project that was internally funded by the Division of Research. So we know that among adolescents, obesogenic behaviors, such as having a sedentary lifestyle and a low quality diet that is high in sugary drinks and low in fruits and vegetables, are some of the key contributors to chronic diseases. We also know that ethnic minority groups, including Latino adolescents, engage in more obesogenic behaviors and have a higher burden of chronic diseases than white adolescents. But within this high-risk Latino population, it's still unclear if obesogenic behaviors are associated with specific individual or neighborhood level characteristics. We know that Latinos are a high-risk population, but if you are a primary care physician, you cannot intervene on race. So we wanted to basically see if you can identify, what are the factors that are associated with engaging in these high-risk obesogenic behaviors that a clinician may actually be able to intervene on. So this was the objective of the study. So this was a cross-sectional study. Data came from over 77,000 Latino adolescents that were ages 13 to 17. These were adolescents who had a well-child visit during 2016 through 2019 in Kaiser Permanente, Northern California. And for those who had multiple teen visits during the time frame, we only used data from their first visit. We specifically measured 4 obesogenic behaviors that are currently captured during these teen visits. And these included consuming low fruits and vegetables, so less than 5 servings per day, drinking a lot of sugary drinks, and that was defined as drinking more than 1 serving of juice or soda per day, having a low exercise, so exercising or playing sports for less than 60 minutes per day. And the 4th was having a high screen time use or watching over 2 hours of screen time. And we also created a composite variable capturing 3 or more of these behaviors. So we looked at the association between these 4 obesogenic behaviors with specific individual and neighborhood level characteristics, including age, sex, household language preference, census-based neighborhood deprivation index, and body mass index, which included 3 obesity subcategories. And just briefly, for anyone that is not familiar with the neighborhood deprivation index, this is an index that includes information about income or poverty, educational attainment, employment, housing, and occupations at the census tract. So this is not an individual level variable. So in our results in the table in the right-hand corner, we can see that our member characteristics, we had a sample that was about 77,000. About 23% lived in homes who reported Spanish as their preferred language. As expected, 43% of the population overall were in the most deprived or in the highest quartile of the neighborhood deprivation index. We found high levels of overweight and obesity. 46% of our sample were in this category, and 27% of adolescents reported 3 or more obesogenic behaviors. In our forest plot in the center column, we can see that when we looked at the composite outcome of having 3 or more of any of these 4 behaviors, we found that older teens engage in more obesogenic behaviors with roughly 30% higher odds of the outcome. And so did those living in more deprived neighborhood deprivation index, and also those in the highest BMI categories. So these findings underscore the need to target lifestyle behaviors at a younger age, way before adulthood, and also emphasize the need to address a combination of both lifestyle factors, but also social determinants of health and caring for children and families, particularly for high-risk populations. These findings can also help pediatricians and healthcare systems identify Latino adolescents at the highest risk of developing chronic diseases. And I just want to finish by saying that as Dr. Jones beautifully summarizes yesterday, it isn't enough to identify and document disparities. We must actually move towards interventions, which is the area where I'm hoping my research will be moving into in the next 5 years. So I'll stop here and I'll be happy to answer any questions.
Thank you so much, Luis. Very interesting. Anything in the chat?
Yes, we have a couple things on the chat. Elissa, thank you. And the question for our presenter is, how do you derive the NDI? Is it publicly available data? Thank you.
Yes, thank you. So the NDI was developed previously, and I'm happy to send the paper if you want to look specifically at the details, but it is a variable that, like I said briefly, is not at the individual level. Is made it's a variable that captures data by the census tract and incorporates a combination of income or poverty, educational attainment, employment, housing, and occupation. And so combining all of these 5 measures, it ranks different census tracts into sort of quartiles or quintiles. Those in the lowest quintile are those who have low poverty, who have high educational attainment, who have stable housing and stable occupations. And those in the opposite end, and the sort of high risk NDI includes neighborhoods that have high levels of poverty, low educational attainment, high rates of unemployment, and low occupation status.
Thank you, Luis, and thank you for reminding us of the excellent points that Dr. Jones made yesterday about documentation without action is doing another Tuskegee experiment. So great point. Thank you for reminding us of that. I don't see any other questions on the chat. Thank you. Let's just give it.
I think, are we supposed to be back in the main session?
We're supposed to be back at 11:10.
Oh,
I certainly don't want to push everyone. If people need a little break, we could take that if there's no more questions.
Well, I have one last question for Luis in that case, if no one else does. So given that statement and sentiment, which absolutely I agree with, and given your current findings, where would you say, understandably, a large observational database doesn't tell us exactly where to what that intervention might be, but what do you think you've learned here that would point you in the direction of where a lever, where an intervention might occur or with whom?
Yeah, that is an excellent question. So I think, to me, one of the most interesting finding of this study was the strong association with the NDI. I think that partnering with community programs who are also trying to address some of these very same issues in our communities, right? I think that having a clinical community partnership working in sync to try to address these issues, I think is one way that could be very beneficial. Healthcare clinical providers are not able to really address all these social needs of our population even if we've identified the need, it's almost impossible to do anything in a 20-minute session. I think really strengthening these community clinical partnerships is one way that I really want to move my research into. It's not going to fix the problem, but I think that it is one step in the right direction of moving moving towards reducing these health inequalities.
Great, thank you. And on that note, I want to just thank all of our incredible presenters today. All of your work's so important and wonderful to have you here, and everyone who attended. And I hope everyone will return to the main session after a 5-minute break. And I believe it's the same link that we were all on this morning. Is that right, Alejandra?
That is correct.
Yeah,
Yes, and we're
great.
hoping to be back there in 5 minutes. So thanks. I just want to reiterate Dr. Carliner's message. Thanks to all of you for your research. It takes a lot of guts to get up here and share your work. It's amazing work. Thank you for your contributions to our communities. So we'll see you in 5 minutes.
Bye, everyone.
Thank you all.
Thank you.